Carpenter. I'd like to thank you for taking the time to join me on today's video. Purpose of today's video is to share with you some information relating to permanent impairments of the shoulder, and I provide today's video for you as sort of an emergency broadcast from ezqmeceu.com. And the reason I refer to today's video as an emergency broadcast is because I want to take special time away from the routine schedule and the routine topics of our blog to share with you some recent discoveries that I've made regarding rating permanent impairments for the shoulder. And those of you that are subscribers to my blog remember that about a month ago I initiated some discussion regarding rating the permanent impairment of the shoulder. And specifically, I surveyed my subscribers as to how they rate the shoulder and how my subscribers use the AMA Guide's description of resection of the distal clavicle in rating permanent impairments related to the shoulder. And I specifically sent out an inquiry to my subscribers asking them to provide me their opinion on the use of resection of the distal clavicle as an analogy in those cases that did not actually involve a resection of the distal clavicle. You see, it's quite easy to provide a permanent impairment rating for the shoulder for resection of the distal clavicle in those cases where the surgical procedure involved resection of the distal clavicle. That's quite easy to do. But I wanted to find out from my doctor subscribers which of those are using resection of the distal clavicle by analogy and which of those doctors are not using resection of the distal clavicle by analogy, and what are the reasons for each position. And I'm going to summarize those discoveries in today's video for you, and I'm going to conclude today's video by providing you a position statement, which is my own position statement regarding the use of resection of the distal clavicle. And so I know that will prove to be very valuable and very informative for you. In addition to discussion today of resection of the distal clavicle, I want to talk about rating the shoulder in general and some of the specific procedures that we use for providing permanent impairment ratings for the shoulder in general. So I consider today's video to be a complete course on the examination, the evaluation of, and the providing of permanent impairment for the shoulder. And we're going to discuss probably the large bulk of the cases that you'll ever encounter in your career as a qualified medical evaluator. Now, certainly there are certain cases that are unique and that have extenuating circumstances that will require creative and specialized and unique permanent impairment ratings. But for the most part, what I want to share with you today will comprise the bulk of the cases that you'll ever see. So I hope you enjoyed today's video, and I hope you get a lot from it. I put quite a bit of research and survey into today's material, so you can be comfortable knowing that today's material is well referenced, and I'll provide those references for you as we go. So I want to give you a minute now to go ahead and get your AMA guides. We're going to be specifically referencing chapter 16, and I'm also going to reference some of the other chapters to illustrate some of the principles that we go over with regards to the shoulder. So you're really going to need your AMA guides. So I'll give you a minute to go ahead and get your AMA guides, and I look forward to being back with you here in just a couple moments as we get into our discussion of rating permanent impairments related to the shoulder. Okay, I'm back with you now, and I have my AMA guides, and hope you have your AMA guides as well. And let's now begin our discussion about rating permanent impairments of the shoulder. Now, I want you to imagine the following scenario. Imagine that you have a QME examination scheduled for tomorrow, and you know in advance that that QME examination involves the shoulder. Perhaps this person had a specific incident of injury to the shoulder, and that is your QME exam for tomorrow. Now, as you begin to prepare for tomorrow's QME examination, you want to start to consider in advance, what are the possible permanent impairments that this examinee could present with. And let me ask you, what are the possible permanent impairments that a shoulder case could present to you at the point in time at which you determine they are at maximum medical improvement. Okay? So the examinee is at maximum medical improvement. What are the permanent impairments of the shoulder? What are some of the things that you're going to examine for the presence or absence of in your examinee that's scheduled for tomorrow? Well, let's talk about that. Okay? Now, by and large, the majority of the permanent impairments that you're going to encounter in your examinee are going to come from what we call the big three. The big three involves loss of range of motion, loss of strength, instability, that is shoulder instability patterns, and then in certain cases, and we'll talk more about this as we go, there may be permanent impairment due to resection of the distal clavicle in certain specific cases, and we'll talk about those types of cases that qualify for permanent impairment due to resection of the distal clavicle. But for the most part, your permanent impairments are going to be comprised either of some combination of loss of range of motion, loss of strength, and or shoulder instability. Now, those are the categories for which the permanent impairments are going to come from under the strict application of the AMA guides. Under a more liberal application of the AMA guides, for example, due to analogy under Alvarez-Guzman 2, what other possible permanent impairments could we find in the shoulder? What are some analogous impairments that we can ascribe to a person who is left with functional limitations of the shoulder? Now, we're not going to go into the many possibilities and the different varieties of analogies for the shoulder, but I want to introduce a concept here that I think may be a unique concept to you. And I want to ask you if you would consider rating the upper extremity by analogy to the lower extremity. Would that fall within the four corners of the AMA guides? Let me ask you, have you ever done that? Have you ever rated an upper extremity permanent impairment by analogy to the lower extremity? Have you ever done that? Have you ever considered that? Would that fall within the four corners of the AMA guides? Well, that's going to be the topic of another video, but I just want to share with you, for the purposes of this video, the idea that you can rate the upper extremity by analogy to the lower extremity. That's within the four corners of the AMA guides, correct? So let me just give you a couple of ideas on that. As you know, in Chapter 16, the upper extremity impairments are based on the following. They're based upon amputations, digital nerve lesions, abnormal motion, peripheral nerve disorder, vascular disorder. They're due to a large category of conditions that the AMA guides refer to simply as the other disorders. And then finally, upper extremity impairments are based on loss of strength. So amputations, digital nerve lesions, abnormal motion, peripheral nerve disorders, vascular disorders, other disorders, and loss of strength. Okay, those are the upper extremity impairments. Now, the lower extremity impairments are many more. And in Chapter 17, the lower extremity impairments are based upon anatomic changes, functional changes, and diagnosis-based conditions. So, for example, relating to anatomic changes, we have limb length discrepancy, muscle atrophy, ankylosis, amputation, arthritis of joints, skin loss, peripheral nerve injury, vascular disorders, and chronic regional pain syndrome. So let's just stop right there with the anatomic changes. One of the anatomic changes of the lower extremities that qualifies for permanent impairment is muscle atrophy. So if you had an upper extremity case that had muscle atrophy, could you provide for permanent impairment for the upper extremity atrophy by analogy to atrophy of the lower extremity? Let me ask you, could you do that? You could do that. That could fall within the four corners of the AMA guides, because muscle atrophy is not specifically described as a permanent impairment of the upper extremity, but it is described as one of the permanent impairments of the lower extremity. What about skin loss? Chapter 17 describes skin loss as a permanent impairment. What if you had skin loss of the upper extremity? Could you provide for permanent impairment for that by analogy to skin loss of the lower extremity? It's my opinion that you could. Okay, Chapter 17 also describes functional changes, including loss of range of motion, gait derangement, and loss of muscle strength. Now, we typically think of gait derangement as being related to the lower extremities, disorders of the lower extremities, or disorders of the nervous system. In fact, gait derangements are described both in Chapter 13, the central nervous system chapter, and Chapter 17, the lower extremity chapter. But don't the arms contribute to normal gait? What's the role of the arms in normal gait? Well, you'll remember that the arms swing reciprocally. It's called reciprocal arm swing. Every time we take a step forward with our right leg, the left arm comes forward. It's called reciprocal arm swing. If you had an upper extremity disorder that interfered with reciprocal arm swing, could that qualify for permanent impairment by analogy to gait derangement from Chapter 17, the lower extremity chapter? It's my opinion that it could. And I introduced this to you here just to give you some ideas as to the multitude of permanent impairment options that we have available to us when it comes time to rating the upper extremity in general and the shoulder specifically. Finally, in Chapter 17, we have permanent impairments due to lower extremity diagnosis-based conditions such as fractures, ligament injuries, meniscectomies, hip and pelvic bursitis, and joint replacements. So, could you provide for permanent impairment for upper extremity bursitis by analogy to lower extremity bursitis? It's my opinion that you could, and I introduced that idea to you here, and we'll elaborate on that in a future video. But as I said earlier, most of the permanent impairments related to the shoulder will come from four main categories, and most of those will come from loss of range of motion, loss of muscle strength, shoulder instability patterns, and then in certain cases due to resection of the distal clavicle. So let me say a few words about each of these: loss of range of motion, loss of strength, shoulder instability patterns, and resection of the distal clavicle. And I'll elaborate most on the shoulder instability impairments, and then also on resection of the distal clavicle. Okay, so let me say a couple words about loss of range of motion. And really the only thing I want to say about that is that range of motion of the shoulder is measured in 6 different planes. We have shoulder flexion, extension, ab and adduction, and internal and external rotation. And remember that we measure these ranges of motion with a long arm goniometer. You need to make sure you have a long arm goniometer in your doctor's bag. We don't measure these ranges of motion with an inclinometer as we do in the spine, but we use a long arm goniometer. And I had one doctor criticize one of my reports, one of my upper extremity impairment ratings, stating that my range of motion measurements were not accurate because I did not use an inclinometer. And the upper extremity measurements at the shoulder are measured with the use of a long arm goniometer. In fact, if you reference the figures that demonstrate the range of motion testing of the shoulder, they specifically depict the use of a long arm goniometer. So make sure that you have a long arm goniometer in your doctor's bag. With regards to loss of strength of the shoulder, remember that we assess strength of the shoulder through the use of manual muscle testing. And I've created a complete 6-hour QME continuing education home study program about manual muscle testing. It's entitled Manual Muscle Testing in the AMA Guides 5th edition. And I highly recommend that program because it goes through you as a complete course on manual muscle testing. And it goes through the specific and different procedures that we use when performing manual muscle testing related to spine injuries compared to the manual muscle testing that we use in relation to extremity injuries. And by extremity injuries, I'm including both upper and lower extremity injuries. So with regards to the upper extremities, recall that with manual muscle testing, we're testing specific motions. Whereas when we are testing, when we're doing manual muscle testing in Chapter 15 for the assessment of the spine and for the assessment of injury to the spinal nerve roots, so-called radiculopathy, correct? We use manual muscle testing to test specific muscles. It's a subtle nuance there in our types of procedures that we use. And I mention that here because I found that some doctors are not aware of this nuance. In Chapter 15, we test specific muscles, specific nerve root innervated muscles. And in Chapter 16, the upper extremity chapter, specifically when assessing for loss of strength at the shoulder, we test specific motions. So we test for strength of shoulder flexion, we test for strength of resisted shoulder extension, resisted abduction, resisted adduction, and resisted internal and external rotation. We test specific motions. Okay? Well, what about shoulder instability patterns? The AMA guides specifically provide for permanent impairment in those situations where the examinee is left with instability of the shoulder. So let's talk a little bit about shoulder instability. And I found that not all doctors assess for shoulder instability. And I really want to encourage you to upgrade and ramp up your shoulder stability examination, because sometimes shoulder instability is the only permanent impairment that you will be able to uncover and discover. Certainly there will be cases where shoulder range of motion is normal, shoulder strength is otherwise normal or mostly normal, but the examinee will be left with some degree of shoulder instability. And that instability can only be uncovered and discovered with a thorough shoulder instability examination. So let's talk a little bit about shoulder instability and your examination procedures for shoulder instability. Okay, so I'd like to have you pull out your AMA guides, and specifically I want to reference here page 504. The AMA guides describe 4 clinical examination findings and or maneuvers for the assessment of shoulder instability, and these are on page 504. The first of these is the sulcus sign. The sulcus sign. Now, what the sulcus sign is a little dimpling in the skin in the case of inferior instability of the glenohumeral joint. Now, the sulcus sign may or may not present at rest. In fact, in some circumstances, you may need to elicit the sulcus sign by applying axial traction down the axis of the humerus bone and adding additional load to the shoulder to expose subtle and occult instabilities. So don't simply look at the examinee at rest and expect to see a sulcus sign in all cases of bona fide instability. Sometimes the sulcus sign is something that needs to be elicited. So you need to have 2 components of your sulcus testing in your protocol. Number 1 is observation for a sulcus sign at rest, and then number 2 is observation for sulcus sign with additional axial loading on down the axis of the humerus. Okay? Then specifically, the AMA guides go into 3 physical examination maneuvers for the assessment of shoulder instability. Now, a little bit of philosophy about the shoulder and shoulder stability testing. The shoulder is surrounded by a joint capsule. The joint capsule has an outer fibrous connective tissue layer. It's actually composed of dense, irregular fibrous connective tissue, high degree of collagen fibers, tiny mix of elastin fibers, and a tiny mix of reticular fibers, but largely disorganized, random, collagenous fibers. And that outer layer of the joint capsule is reinforced by intrinsic ligaments. By intrinsic ligaments, we mean that there are localized thickenings of the capsule. And we refer to these capsular ligaments as the glenohumeral ligaments. And the glenohumeral ligaments are oriented circumferentially around the shoulder joint capsule. And so we have anterior glenohumeral ligaments, we have posterior glenohumeral ligaments, we have inferior glenohumeral ligaments. And with injury or damage to the capsule and these intrinsic ligaments, the head of the humerus can become unstable and sloppy within the glenoid cavity. And that creates the shoulder instability patterns for which the AMA guides provide for permanent impairment. Now, we assess for shoulder instability patterns through the use of 3 physical examination maneuvers that are described in the AMA guides. We have the loading anterior to posterior drawer test, we have the apprehension test, and then in the case of positive findings on the apprehension test, we have Job's relocation maneuvers. So I'll describe each of those maneuvers as well as a couple of additional physical examination maneuvers for the assessment of shoulder instability. Okay, so with the loading anterior to posterior drawer test, we perform loading up the axis of the humerus in a posterior direction and in an anterior direction to look for excess translation of the head of the humerus within the glenoid cavity. Now, the AMA guides describe the position that we use for testing the anterior to posterior loading maneuver. They describe the maneuver as being done in 60 degrees of abduction with humerus neutral rotation and 30 degrees of flexion. Okay, so let's demonstrate that. Here's 30 degrees of flexion. Here's 60 degrees of abduction. This will be 90 degrees. This would be 75. This is 60 degrees of abduction, 30 degrees of flexion with neutral humerus rotation. In this position, you as the examining doctor provide a load to the humerus in a posterior direction, in an anterior direction, posterior, anterior, and you assess for movement of the head of the humerus within the glenoid cavity. Now, I want to encourage you to perform this maneuver in a variety of positions, not just 30, 60 neutral rotation, because how many of our examinees are going to exactly fit the description as it's described in the AMA guides? Many examinees, they never read the book, right? And isn't that the way most examinees are? They're never exactly textbook. And so you may need to perform this maneuver in a variety of positions to expose and uncover these subtle and occult instabilities. So you would try it here in 0 degrees of abduction but varying degrees of flexion, and no flexion but varying degrees of abduction, and all combinations in between to help uncover and discover these occult instabilities. So I want to encourage you to assess for multiplanar instability and not simply rely upon the one maneuver as is described in the AMA guides. The second maneuver that the AMA guides discuss is the apprehension test. The apprehension test. And I want to talk a little bit to you about the apprehension test and the apprehension sign. And you will probably recall that we have other physical examination maneuvers that rely on the apprehension test and the apprehension sign. For example, we also have an apprehension test and an apprehension sign in testing for the stability of the patella. We have the patellar apprehension test. And what exactly do we mean when we talk about the apprehension test, and what exactly is the apprehension sign? And I remember learning about the apprehension test, I think it was in the 3rd year of chiropractic school. I'm a chiropractor. And you probably learned about the apprehension test as well. And I remember that when I learned about the apprehension test, I never really took it seriously as a bona fide physical examination maneuver, because I thought to myself, what is the possibility of an examinee whose arm is placed in 90 degrees of abduction and neutral degrees of rotation, and as we apply increasing external rotation to the humerus bone, what is the chance of an examinee putting forth an apprehension sign, such as, "Oh," or "Ah," or "Ah"? Don't do that. And so that's how the apprehension test was taught to me in chiropractic school. So I never really took it seriously as a reliable physical examination maneuver, and I pretty much discounted it. Well, in recent years, I've come to understand the apprehension test and the apprehension sign a little differently, and I want to share some ideas with you here. Now, what the apprehension test is designed to assess for is laxity and impending subluxation and or dislocation of the head of the humerus from the glenoid cavity. Now, as the head of the humerus begins to sublux in a bona fide case of instability, as the head of the humerus begins to sublux from the glenoid cavity, your examinee will detect this and they will let you know. How will the examinee let you know? Well, the examinee will let you know through what's known as an apprehension sign. So, what is an apprehension sign? An apprehension sign from the examinee is some sort of maneuver, some sort of a recoil, some sort of a reflex, some sort of a withdrawal from the stimulus that is pending subluxing their shoulder. It's a withdrawal reflex from the anti-survival painful situation of having the shoulder begin to come out of its socket. It's typically associated with some type of a muscular reaction, a withdrawal, a contraction. In fact, the AMA guides, they refer to this as muscular defense. This is on page 504 in the AMA guides. The AMA guides say that if the test is positive, the individual fears that the humeral head will slide out, causing pain. Muscular defense against the motion is usually present. It's the muscular defense against the motion that constitutes the apprehension sign. And it's the muscular defense against the motion that constitutes a true objective finding for this maneuver. Okay? What is not the true objective finding of the apprehension sign? Okay, I can tell you that the words and expressions of your examinee do not constitute the true objective finding. Okay, a true objective finding is not your examinee stating, ow! Stop that! I'm apprehensive. My subluxation is going to pop out. That is not the true positive finding for the apprehension test. The apprehension test involves a muscular defense, the purpose of which is to minimize the possibility or the potentiality of the head of the humerus sliding out of the glenoid cavity. So if we elicit the apprehension sign by abducting the arm to 60 degrees and then externally rotating the head of the humerus, creating instability of the glenohumeral joint, a positive muscular defense, a positive apprehension sign might look something like this, which reduces the external rotation. Or it might be something that reduces the abduction. Or it might be a combination of the two. Some reaction, some involuntary reflexive reaction from the examinee that reduces the possibility of subluxing the head of the humerus. Okay? So you want to be on the lookout for this muscular defense. Now, this muscular defense is a lot like a flexion withdrawal reflex. You'll be familiar with the flexion withdrawal reflex if you've ever touched your finger to a hot stove. You touch your finger to a hot stove and instantaneously and reflexively and unconsciously there's a withdrawal a reflexive contraction of agonist muscles, in this case the biceps brachii muscles, to withdraw your finger from the anti-survival, painful, tissue-damaging stimulus. Isn't it great that you don't have to think about the flexion-withdrawal response? Well, similarly with the apprehension test, the examinee doesn't think about it. They simply react unconsciously. It's a form of the flexion-withdrawal reflex, and you want to be on the lookout for the true objective finding, which is the apprehension sign. Now, according to the AMA guides, in the presence of a positive apprehension sign, we can perform a validity maneuver, which they refer to as Job's relocation test. Now, with Job's relocation test, you as the examiner perform any of a series of maneuvers, the purpose of which are to reduce the pending subluxation. So typically, the Job's relocation maneuver is described, and this is the way that AMA guides describe it. They describe it as applying a posteriorly directed force through the head of the humerus, the purpose of which is to slightly, I'll show this way, is to slightly reposition the head of the humerus back in to the glenoid cavity to prevent it from sliding this way anteriorly. So the Job's relocation maneuver relocates the head of the humerus back into the glenoid cavity, which should then relieve your examinee's apprehension. Now, Job's relocation maneuver can be done in any of a variety of ways, and a variety of ways that are less cruel than leaving the examinee in this apprehension position where they fear that their humerus is going to slide out of socket. You could, for example, as the examiner, you could yourself reduce the external rotation. That should make the examinee more comfortable. You could reduce the abduction. You could change the angle to make them more comfortable, and that would be a validity maneuver for the apprehension test. Okay, so those are the four maneuvers that are described in the AMA guides. We have the sulcus sign, the loading anterior and posterior drawer test, the apprehension test, and then Job's relocation maneuver. I'm going to recommend that you incorporate a couple of additional physical examination maneuvers as well, including the fulcrum test and the labral clung test. And I like both of these maneuvers, and I demonstrate these maneuvers for you on a different video, and you can access that by way of my YouTube channel. And we don't have time or the capacity to do that because it requires a third-party examinee here. But I like these additional maneuvers because both the fulcrum test and the labral clung test allow you to assess for instability in a variety of different test positions. Both of these examination maneuvers are done with the examinee supine. So it allows you as the doctor to ride around on your doctor's stool and assess the shoulder in a variety of different positions to pull out and expose those subtle and occult instability patterns. And the labral clung test adds another dimension in that it allows rotary movements or rotational movements of the head of the humerus as you as the doctor take the shoulder throughout various planes. So you can also assess for rotational instability as well. And sometimes it's these additional subtle examination maneuvers that expose instabilities that you would otherwise not be able to detect, certainly with just the four maneuvers that are described in the AMA guides. So I want to encourage you to upgrade and ramp up your shoulder instability examination and make sure to perform a thorough instability examination maneuver on all your shoulder cases from here on out, because many times it's the shoulder instability that's the only permanent impairment upon which you can provide for a permanent impairment rating. Now, finally, with regards to shoulder instability, many times with shoulder instability testing, in addition to muscular defense, you will encounter pain. And pain is very specific, and when the pain is specifically localized, that constitutes a true objective findings. Now, the AMA guides refer to the pain associated with shoulder instability testing. And they state, and this is here on page 504, they state that, as I said earlier, muscular defense against the motion is usually present. However, presence of pain alone is not necessarily diagnostic of instability. So your examinee can have pain, but that in itself is not pathognomonic of shoulder instability. More pathognomonic of instability is the muscular defense, the so-called apprehension test. But you may also see pain manifesting prior to the apprehension sign. So, for example, in the early stages of apprehension testing, the examinee may report pain, whereas if you continue the examination maneuver further, that's when they get the muscular defense apprehension sign. So let me ask you this question. If you had a case of bona fide anterior shoulder instability, let's say there was an injury to the anterior glenohumeral ligaments, and the shoulder was left unstable, and you provoked that instability in a bona fide case of anterior instability, which is the most common, where would the pain be? Where would you expect to find pain? Let me ask you. Would you expect to find pain in the clavicle? Probably not. Would you expect to find pain in the coracoid process? Probably not. Would you expect to find pain at the acromion process? Probably not. Where would the pain be in the circumstance of impending or provoking anterior subluxation? Okay, I'm back with you now, and I'd like to conclude today's video with a brief discussion about resection of the distal clavicle. So I'd like to have you open your AMA guides to page 506 as we talk about this topic. Now, as I said earlier in the beginning of this video, I queried and surveyed my doctor subscribers as to how they rate the shoulder in those cases that involved shoulder surgery, but the shoulder surgery did not involve the actual exact procedure of resection of the distal clavicle. And if you've been doing this for any length of time, and if your QME practice is anything like mine, you're getting shoulder cases. And I've had probably hundreds of shoulder cases. And in reading through the medical records of these shoulder cases, many of these examinees do end up having surgical corrections for the shoulder. And operative procedures on the shoulder are many. And so let's just list some of the operative procedures. And this is not necessarily a complete list. But what are some of the operative procedures that take place or can be done on the shoulder? For example, examinees frequently have rotator cuff repairs, full thickness rotator cuff repairs. They have subacromial decompression. They have subacromial bursectomy. They have debridement of articular scuff lesions and debridement of bursal-sided scuff lesions. And they have biceps tenodesis procedures. And they have resection of the distal clavicle procedures. And all these different shoulder procedures can be done. Well, it's interesting. If you look at table 1627 on page 506 of the AMA guides, only one of those procedures is listed in the table. Only one of those procedures qualifies for permanent impairment. It says here that resection of the distal clavicle qualifies for 10% upper extremity impairment. There is no provision for permanent impairment due to rotator cuff repair. There is no provision for permanent impairment due to subacromial decompression. There is no provision for permanent impairment due to biceps tenodesis. Now, the biceps tenodesis procedure involves a removal of the long head of the biceps tendon from the superior rim of the glenoid cavity and from the glenoid labrum, and replacing and reattaching the long head of the bicep tendon with surgical hardware into the head of the humerus bone. A substantial procedure that creates anatomic change, permanent anatomic change, and permanent installment of surgical hardware, and yet the AMA guides do not provide for permanent impairment due to biceps tenodesis. Isn't that incredible? The only procedure for which the AMA guides, the only surgical procedure for which the AMA guides provide for permanent impairment, is a resection of the distal clavicle. Now, I want you to imagine the following scenario for me. Imagine that you have an examinee who has a surgical procedure including resection of the distal clavicle. And imagine that this examinee has a complete and fabulous recovery from this procedure. I mean, isn't that the purpose of these surgical procedures, is to make the patient better? Isn't that the purpose of these surgical procedures? So imagine the rare case where the examinee gets better. Imagine that the examinee is a professional athlete. And we see professional athletes in workers' comp nowadays, correct? So imagine that this examinee has a fabulous repair, has a beautiful rehabilitation program, thorough rehabilitation program where cost is, there's no sparing of expense, and we have a highly motivated athlete, and the athlete returns to full physical function. Imagine a quarterback going back to throwing the football. So, according to the AMA guides, this examinee, professional athlete quarterback, would qualify for 10% upper extremity impairment on the basis that the surgical procedure involved resection of the distal clavicle. See, the permanent impairment related to resection of the distal clavicle is unrelated to functional deficits. It's independent of the functional status of the examinee. And we use the example where the professional athlete returned to play. He returned to full functional status, and yet according to the AMA guides, qualifies for permanent impairment. It's quite interesting, actually. So, what about biceps tenodesis? It's not listed. What about rotator cuff repair? It's not listed. Subacromial decompression? It's not listed. So, the question is, and the question becomes, what is the permanent impairment associated with resection of the distal clavicle? And why is resection of the distal clavicle uniquely provided and supported in the AMA guides with a permanent impairment rating, whereas none of the other surgical procedures are? Well, let's talk a little bit about the function of the distal clavicle and see if we can illustrate why it is that resection of the distal clavicle is unique. Okay, I want to draw your attention now to the whiteboard here. And I hope you can see what we're doing. Let's talk a little bit about the distal clavicle and the acromioclavicular joint. Now, the acromioclavicular joint is classified as a diarthrosis synovial joint. If you remember back to Arthrology 101, you remember that we classified joints according to their structure, or we classified joints according to their function. So structurally speaking, there are three types of joints. There are fibrous joints, cartilaginous joints, and synovial joints. And then functionally speaking, we talk about joints based upon the amount of motion that they allow. So based on the functional classification of joints, we have synarthrosis joints, amphiarthrosis joints, and diarthrosis joints. And it's the diarthrosis joints that are the freely movable joints. So the acromioclavicular joint is a diarthrodial synovial joint. Now, all synovial joints in the body share 5 common features and characteristics. Number one is that all synovial joints have articulating cartilage. And the acromioclavicular joint has articulating cartilage on both the end of the distal clavicle and then also on the medial facet of the acromion process. And we'll diagram that in just a minute. All synovial joints have a synovial cavity. All synovial joints have an articular capsule. All synovial joints have synovial fluid. And then all synovial joints have reinforcing ligaments. And those reinforcing ligaments can be one of 3 different varieties. They can be intracapsular ligaments. They can be intrinsic ligaments, meaning built into the articular capsule itself, or they can be extrinsic ligaments as well. So let's diagram out the acromioclavicular joint as we illustrate permanent impairments related to resection of the distal clavicle. Okay, so here we have the acromion process, and here that's the acromion, and this is the distal clavicle. And I'm drawing the acromioclavicular joint here much enlarged so that we can see some of the structures. Now, both the end of the acromion process and the end of the distal clavicle are lined with articular hyaline cartilage. And these are the parts of the bone that come in contact and where movement is created. Okay? Now it's interesting because the articular cartilage on the distal clavicle projects about 1 to 1.5 centimeters approximately from the end of the distal clavicle. So there's our articular cartilage. Now the acromioclavicular joint is surrounded by an articular capsule. And the capsule separates the exterior of the joint from the interior of the joint. Okay? Now, the articular capsule is composed of two types of tissue. The outer layer of the articular capsule is fibrous connective tissue. It's dense, irregular, fibrous connective tissue, largely composed of collagen fibers. The inner aspect of the articular capsule is lined with a synovial membrane. We'll highlight that in red. And it's the synovial membrane that secretes synovial fluid into the synovial cavity. Okay? Now, the articular capsule is reinforced with ligaments. And with regards to the acromioclavicular joint, the ligaments of the acromioclavicular joint are known as intrinsic ligaments, meaning that they are built into the articular capsule itself. They're thickenings or expansions of the articular capsule itself. And typically in the acromioclavicular joint, we think of superior acromioclavicular ligaments, a thickening of the articular capsule superiorly, and we think of inferior acromioclavicular ligaments, which are thickenings of the articular capsule inferiorly. Now, the superior and inferior acromioclavicular ligaments continue circumferentially around the acromioclavicular joint, so they continue anteriorly here in this direction, and then posteriorly in the posterior aspect of the acromioclavicular joint, they continue posteriorly as well. So you can see that the acromioclavicular ligaments provide stability to the acromioclavicular joint superiorly, prevent the clavicle from moving superior, prevent the clavicle from moving inferior, and then also prevent the clavicle from moving anterior and posterior relative to the acromion process. Now, the articular capsule of the acromioclavicular joint attaches approximately 2 centimeters proximal to the distal aspect of the acromioclavicular joint. Okay, so that's the anatomy involved. Now, with a resection of the distal clavicle, involves removal of a variable amount of this distal aspect of the clavicle. A variable amount. And the distal clavicle is removed for a variety of reasons. Number one, to relieve pain and problems from the acromioclavicular joint itself, and also to reduce impingement on other structures that would be due to osteophytes and bone spur projections from the clavicle and or the acromion process. So typically, the distal clavicle is removed, and the inferior and anterior aspect of the acromion process is contoured and removed to increase the subacromial space and reduce impingement on other structures such as the rotator cuff and the subacromial bursa. Okay, so that's the anatomy involved. So what about providing for permanent impairment due to resection of the distal clavicle? Well, in those cases where a distal clavicle excision is performed, the guides are clear on that. Now, let me ask you this question. Why do you think the AMA guides would provide for permanent impairment due to resection of the distal clavicle? In other words, to re-ask that or rephrase that question, what is the permanent impairment caused by a loss of a small piece of bone that does not involve damage to the articular capsule, does not disrupt the production of synovial fluid, does not disrupt the hyaline cartilage, at least on the end of the medial facet of the acromion? What is the permanent impairment? What's the big deal about resection of the distal clavicle? Well, it has to do with the function of the clavicle itself. And the clavicle serves as a strut, as a spacer, to maintain two distances. Number one, it maintains the distance of the shoulder blade away from the sternum bone. If you've ever seen those people that are born without collarbones, you know that they can bring their shoulder blades right around to their chest bone. Well, the clavicle prevents the scapula from approaching the sternum bone by maintaining that distance. Secondly, the clavicle maintains separation of the scapula from the thoracic wall. And when the distal aspect of the clavicle is removed, I'm not sure you can see that from that this camera angle, but when the distal aspect of the clavicle is removed, that spacer, that strut, is modified, and this permanently alters the structure of the shoulder and also the function of the shoulder. And the AMA guides, by way of consensus panel, have arrived at a 10% upper extremity impairment for those cases that involve this actual procedure. Now, in cases where the surgical procedure does not involve resection of the distal clavicle, we don't have this permanent impairment. And when I ask doctors whether or not they provide for permanent impairment by analogy to resection of the distal clavicle, some doctors have responded that yes, they do. Routinely, as a matter of course, if the examinee has had a surgical procedure, even if it's not a resection of the distal clavicle, then they provide for permanent impairment by analogy to resection of the distal clavicle. And I've asked doctors, well, why? Why do you opine for permanent impairment by analogy? And some doctors have simply told me that they feel that, in their opinion, they need to provide for permanent impairment simply due to the fact that the examinee had a surgery. Doesn't matter what kind of surgery, but the fact that they had surgery and they were exposed to anesthesia, and they were exposed to infection in the hospital, and they had their joint opened and permanently anatomically altered, that because of the surgical procedure, they provide for permanent impairment by analogy to the only surgical procedure on the shoulder that the AMA guides provide for. And I want to talk to you about this for just a couple minutes, because in my opinion, I believe, and it's my position, that this should not be a matter of routine and a matter of due course in each shoulder case. Now, there will be some shoulder cases wherein you do opine for permanent impairment by analogy to resection of distal clavicle. And I myself have opined both ways. I have opined for impairment by analogy to resection of the distal clavicle, even when there was no resection. And then I have opined against permanent impairment when there was no resection. So I myself have done it both ways. But I'm of the newer opinion that unless there's extenuating circumstances, or unless the surgical procedure very closely resembles a resection, or the permanent impairment very closely resembles the permanent impairment associated with a resection, then in general, the examinee would not qualify for permanent impairment by analogy to resection of the distal clavicle. And there's basis in the AMA guides for this. There are other surgical procedures described in the AMA guides, extensive procedures actually, for which there is no permanent impairment rating. And let me just give you a couple of examples here. And there's even one in Chapter 16, the upper extremity chapter, which is what we're investigating here today. I'd like to have you turn to page 495 of the AMA guides, where the AMA guides describe permanent impairments related to carpal tunnel syndrome. Now, in the AMA guides, they provide for permanent impairment due to carpal tunnel syndrome in post-surgical cases. Okay, we're talking about post-surgical shoulder, and we're going to contrast and illustrate shoulder principles by referencing some principles associated with carpal tunnel syndrome. So, the AMA guides describe 3 possible scenarios of outcomes following carpal tunnel syndrome surgery. And option number 3, I want you to imagine this. You have an examinee that comes in to you, and they report symptoms of classic carpal tunnel syndrome. They have numbness and tingling in the hand. They have weakness in the thumb and fingers. They are dropping objects according to their report. They demonstrate a positive flick sign and all this stuff that we associate with carpal tunnel syndrome. However, by physical exam, you find that they have normal sensibility, meaning they have normal 2-point discrimination and normal Semmes-Weinstein monofilament testing. In other words, their sensory exam is normal. And they have normal thumb opposition strength. In other words, the motor function of the median nerve is normal. And they have normal nerve conduction studies. Then the AMA guides state that there is no objective basis for a permanent impairment rating. There is no objective basis for a permanent impairment rating. So you might ask, well, what about the objective fact that they had a surgical procedure on the wrist, that they were exposed to anesthesia, that they were exposed to risk of infection, that they had to take dangerous and possibly addicting medication after the surgery, that they had their wrist anatomically permanently altered? The guides say that there's no objective basis for a permanent impairment rating, despite the fact that there was a surgical procedure. And that's not the only example in the AMA guides. The AMA guides state in Chapter 6, the digestive system chapter, that you can have an extensive surgical procedure on the digestive system, but resume normal function and have no interference with activities of daily living, and qualify for 0% whole person impairment. And I draw your attention to page 122, example 6-3, wherein a 35-year-old man had a 30 centimeter, how much is 30 centimeters? Is that 12 inches? Had 12 inches of his terminal ilium resected, and also had a ilio-ascending colostomy construction. Qualified for 0% whole person impairment despite an extensive and permanent anatomic alteration of the digestive system because he returned to normal activities of daily living. And the same can be said in the shoulder. Simply having a surgical procedure on the shoulder in and of itself, in my opinion, does not qualify for permanent impairment by analogy to resection of the distal clavicle. As another example, the AMA guides provide for 0% whole person impairment due to splenectomy. So let me read you from Chapter 9 what the AMA guides say about splenectomy and the spleen. States here on page 199 that a normal spleen cleanses the blood of bacteria and other foreign matter. Splenectomy removes a quarter of the total lymphoid tissue and the major mass of macrophages. As a consequence of splenectomy, some functional abnormalities may develop. These include impaired clearance of certain encapsulated bacteria, such as the pneumococcus. Occasionally, individuals develop overwhelming infections after splenectomy. However, in example 9.9, they give an example of a 21-year-old man who ruptured his spleen in an automobile accident. He had a splenectomy. He had an uneventful post-operative course. And imagine your shoulder cases that have uneventful post-operative courses. He returned to all activities in 2 months, and he qualified for 0% impairment of the whole person. So I think the AMA guides are clear, at least in those 3 isolated examples of carpal tunnel syndrome, digestive system surgery, and splenectomy, that simply for the surgical procedure, there is no impairment of the whole person following the surgical procedure itself. And it's my opinion, and it's my new position, that that applies to the shoulder as well. Now, there are other surgical procedures of the shoulder that you may opine are similar to a resection of the distal clavicle. For example, you may opine that a claviculoplasty procedure, which involves the removal of osteophytes and the contouring, but not the removal of, the contouring of, but not the removal of the distal clavicle, you may opine, and I've done it myself, you may opine that that qualifies for permanent impairment by analogy to resection of the distal clavicle. But I want you to know that should that case come to deposition, your opinion on analogous permanent impairment to resection of the distal clavicle is going to be challenged. And when it comes to defending your opinion, your how and your why has to be good. It's going to have to be good to stick. Okay? So, others may opine that a subacromial decompression, because of its proximity to the acromioclavicular joint, and because it can possibly permanently alter the anatomy of the joint, you may use these as various supportive reasons to substantiate your opinion. But as I said, if it's challenged, your how and your why is going to have to be good. Okay? So let's review and let's conclude our video today. We're talking about permanent impairments related to the shoulder. As I said, the bulk of your permanent impairments are going to come from losses of range of motion, loss of strength, and instability patterns. Now, of those 3, range of motion is the one that can be most universally combined with the others. Losses of range of motion can be most universally combined. In certain cases, you may opine for permanent impairment due to shoulder instability, and I want to encourage you to ramp up and upgrade and thoroughly investigate shoulder instability on each of your cases, because I found through my own experience that many times patients present with instability patterns that can only be found by thoroughly looking for them and thoroughly anticipating them in advance. And then finally, we talked about resection of the distal clavicle, and I'm going on record here now with you in this videotape after surveying my doctors and researching the matter, that my new opinion and my new position is that in those surgical cases that do not involve a resection of the distal clavicle, providing for permanent impairment by analogy to resection of the distal clavicle is something that I personally am going to be doing with less and less frequency than I once did for the reasons that I stated in this video. Does not mean that you cannot do it. It does not mean that if you do provide for that analogous impairment, does not mean that that opinion won't be held up. It just means that I would expect that that opinion is going to be challenged when the surgical procedure does not actually involve a resection of the distal clavicle. So I want to conclude the video with just one more comment, and that is I look forward to your feedback and your ideas on these topics, and I specifically solicit your feedback and ideas on permanent impairments related to the shoulder. You know, I have the interesting position of being the guy who's in front of you and the guy who's producing these videos, but I want you to know that I do not in any way consider my say on the matter to be the final say, and I look for opinions and conclusions and ideas from you so that I can pass those on to my subscribers and educate my subscribers on some of the different ideas that are available to us in our industry. So please feel free to write me with your ideas, your feedback, your comments, or any suggestions that you may have. So this is Dr. Perry Carpenter. I want to let you know it's my pleasure to bring you these videos, and I look forward to being with you on future videos. I hope today's material has been enlightening and useful to you. And for now, I want to conclude by wishing you the best of success in your career as a qualified medical evaluator.